Yves owns a private specialist centre in Hampshire, and he's been using shockwave therapy since 2013. As I say, he started off with a radial device and then added the focus device. And in the last week, he supplemented his arsenal of machines with the recently launched MagnetoLeaf, which he'll tell you a bit more later. In his practice, he uses shockwave for MSK, urology, and dermatology conditions. So, Yves, you're very welcome. Thanks very much for taking us all today through this presentation. And I'll pass over to you.
Okay, thank you very much, Hugh. Good morning, everyone, and thanks for the introduction, Hugh. So really, you know, what I want to do is to just spend some time with you guys talking about, you know, shoulder calcific tendinopathy, and then more specifically, the shockwave therapy within this particular condition. So basically, it is a common condition which is caused by deposition of calcium crystals in the rotator cuff or in the subacromial subdeltoid bursa. It occurs in about 2.5 to 7.5% of healthy shoulders, mainly affecting women, you know, typically sort of aged between 40 and 60. And 10 to 20% actually tend to demonstrate bilateral symptoms. Sorry?
No, it's okay. Somebody had their camera on. I was just going to ask them to turn it off, but they've turned it off. Rakar's turned his camera off.
Okay, thank you. So it accounts for 6.8% of all shoulder pain, and it tends to be more common in office workers, cashiers, you know, sort of production line workers who have their arms in internal rotation and slight abduction for extended periods of time. We've seen in most tendinopathies now very much a split between metabolic input and you know, load. So we now know that for instance, in calcific tendinopathy, that, you know, 64.7% of cases, there is a certain amount of endocrine involvement. So, you know, thyroid problems, menopause. We also see a higher incidence in our diabetic patients, and it's also linked to rheumatological disease, gout, hypercalcemia. So 70% now is sort of looked at with being more related to metabolic disorders, and perhaps 30% load. So where does it happen most? Is basically in the supraspinatus tendon. So there are mixed reviews and evidence of its prevalence, ranging between sort of 51 and 90% in the supraspinatus muscle. On average, from the research evidence out there, it's about 80%. So 80% of all calcific tendinopathy happens within the supraspinatus muscle, to a lesser extent in infraspinatus, and even lesser extent into subscapularis. Typically, it tends to happen towards the insertional side of the tendon, in what's kind of classed as the sort of critical zone due to possible poor vascularization. The pathogenetic mechanism is still unclear, so there's lots of different hypotheses out there suggesting different mechanisms at play. Degenerative, repeated trauma, tenocyte necrosis, reactive. So typically you're sort of compression leading to tissue hypoxia, and then onward to creating a tendinopathy. It's looked at the sort of 3 specific stages of this calcification process, in such that you have a pre-calcific state, you have a calcific stage, and a post-calcific stage. Within the calcific stage, there's a formative phase, a resting phase, and a reabsorption phase. Often the painful phase is put towards the reabsorption phase. However, quite a lot of research out there is implying that there's not a lot of good evidence to support symptoms and these phases. The pre-calcific phase is often a phase where there is, no symptoms at all, and then in the third phase is basically where the healing and tendon repair tends to occur. There is a natural cycle towards being a self-healing tendon. So most of the time, everybody will say that it's self-healing. However, the cycle may not follow its own pattern and can be blocked at any point. It's interesting then that the poor vascularity may actually not be the cause for the tendon degeneration, but maybe the reason why the self-healing capacity of the body tends to fail. So what's the clinical presentation? Well, one of the main symptoms is pain. Patients will often present twofold. They'll either have a more acute, very painful shoulder, or a sort of shoulder that's been grumbling for a long time with a sort of low-grade pain. We also know that it can be an incidental finding and that there can be no pain at all. They may present with restriction of joint mobility, but not always. Often they will complain of pain at night, difficulty lying on that side, and pain made worse with movement. So from a pain perspective, we get an increase in intratendon pressure, with then also an increase in tendon volume, which means that the tendon can get compressed under the coracohumeral arch, leading to your typical subacromial impingement. This leads to functional loss and disability, followed by obviously losing strength, lack of motion, and typically you get that sort of localized pain in the deltoid region, which is often made worse with overhead activities like cleaning windows or the roof of a car, picking something up at arm length, those kind of activities. So overall, it's affecting people's daily life, quality of life, and sleep, and also can cause quite a significant amount of anxiety and distress. As we get increased calcification, there is a chance of partial tendon rupture. However, complete rupture tends to be quite rare. There's also often an association between supraspinatus tendinopathy and bicipital tendinopathy. Both tendons are classed as being main stabilizers of the glenohumeral joint. The supraspinatus has a role in stabilizing the long head of biceps tendon, and it forms part of the long head of biceps tendon reflection pulley, which basically means that any damage to either one can affect the function of the other one. So we also know that with increased chronicity of the supraspinatus tendinopathy, that the biomechanics of the shoulder joint will become affected, which is then also likely to present with associated pathology in other tendons, and often that is the long head of biceps. So from a differential diagnosis, there's obviously different conditions that will resemble calcific tendinopathy, and this can be quite difficult in the early stages of the condition, especially sort of frozen shoulder, who can really mimic this quite well. But I think one of the ways that you can clinically differentiate would be that with frozen shoulder, you get your typical loss of external rotation, which you don't really tend to get with your calcific tendinopathy. We can then move on to doing, obviously, imaging and to look for calcific deposits in order to strengthen our hypothesis and ultimately come to a diagnosis. So with radiology, there are numerous sort of classifications, and they're basically either based on the size of the deposits or the morphology. Probably the two most used ones in clinical research is Bosworth, Bosworth and Gardner. Bosworth very much looks at size, describing a small deposit as anything below 0.5 centimeters, a medium deposit anything between sort of 0.5 and 1.5 centimeters, and a large is anything which is bigger than 1.5 centimeters. So this becomes clinically relevant, which I will demonstrate at a later point, that actually size does matter. With Gardner et al., he looked at 3 different types dependent on the shape and what it looks like. So type 1 is a well demarcated dense deposit. Type 2 has soft contour, dense or sharp, transparent morphology, and then the type 3 is soft in contour, is translucent, and is cloudy. And again, this becomes quite important with regards to looking at when we can be effective for certain types of deposits in size and shape. Bianchi and Martinoli described sort of 3 types of classifications of calcifications under ultrasound scanning. Type 1 is a hard calcification, hyperechoic, with strong acoustic shadowing. So what that basically means is that it's to do with the brightness. So hyperechoic means that it's more bright than the surrounding tissue, and the acoustic shadowing is all to do about reflection. So type 2 is a softer calcification, and the brightness of it is almost similar to the surrounding area. And then type 3 is a fluid calcification, which becomes hyperechoic, which means that it becomes darker, and there is no acoustic shadowing, so there's not a lot of reflection there. Again, these kind of findings become important with regards to our management strategy. So, does the size matter? Well, a study by Le Goff looked at exactly that, and they looked at a comparison between symptomatic and asymptomatic shoulders, and basically what they found was that patients presented with symptoms when the calcification was bigger than 1.5 centimeters. So it does appear that the volume and the size of the calcification is directly related to symptoms. MRI scan, it's kind of not recommended. It's obviously expensive over ultrasound scanning. It's not always well tolerated by patients. Access can be difficult as well in the NHS. And although it offers excellent soft tissue contrast, sometimes calcifications can be difficult to differentiate from other tissue interfaces or hemorrhaging. So it's not really the first choice. So when we're looking at treatment options, then in the first instance, we have our conservative management, looking at one of the main sort of things that often gets addressed is the pain. So in the acute phase, patients are being prescribed NSAIDs. However, there is no research evidence to support its effectiveness. Physiotherapy will mainly be targeting range of motion exercises to avoid any kind of stiffening of that joint, and also looking more at the subacromial impingement, trying to restore the normal scapular mechanics and normal muscle balance around the shoulder and trunk. When we're looking at steroid injections, again, they're often administered for helping pain in the acute phase. However, again, there's poor effect, but also they even found that there can be a negative effect because it could interrupt the reabsorption of the calcium deposits. So about 27% of conservative management is thought to fail to help patients. There are some prognostic factors within our conservative management, which also helps with our choice regarding treatment. So potential negative prognostic factors are bilateral presentation. Often I have found that you see a patient who may have bilateral calcium deposits, but is actually only painful in one side. Delocalization near the anterior portion of the acromion, and then also when it extends into the subacromial bursa and the subdeltoid bursa, it basically just means that the larger and the further it extends into the cuff, the poorer the potential outcome, and obviously the size of calcium deposits. Positive prognostic factors, and this is coming back to what we can see on imaging, is that the Gardner type 3 calcific deposits, which are visible on X-ray, they tend to respond better to shockwave treatment and conservative treatment, but also the lack of sonographic sound extinction. So when the sound waves are not reflected, then you have more of a chance of being successful with your treatment. So that's in your type 2 and type 3 on ultrasound scanning. So having that information obviously at hand can be very helpful when you're trying to decide together with your patient with regards to what treatment you plan to do. So when we're looking at PRP and surgery, there is conflicting results regarding the effectiveness of PRP, and especially within the sort of shoulder and rotator cuff, there really is a lack of studies. There's not a lot that one can say for its use within shoulders. There's obviously surgery. So the aim of the surgery would be, in the first instance, to try and remove the calcium deposits. Some thoughts there that some surgeons will claim to do partial. It's not necessary to do complete. Other ones will say that you want to take away everything. Next thing to look at then is whether to suture or to non-suture the remaining gap. Surgeons advocating suturing claim that they want people to have an early start on rehab, and they feel that by providing a suture that people can just progress into their rehab quicker. And then there is agreement from a surgical perspective to actually do a subacromial decompression if there are signs of subacromial impingement.
Can I just say that if anybody's got any questions, please put them in the chat room and then we'll pick them up afterwards. Thanks.
Okay. Yeah, thanks, Hugh. So what about shockwave therapy then? So, I mean, a lot of the research questions that have been sort of asked, is it safety? Is it effective? What does it do to pain? Is it successful? What about sort of the resorption of these calcium deposits? You know, is it helpful short term, long term? And what do we use? Do we use high energy, low energy? So I'm just going to go through a series of different research articles trying to address these various sort of research questions. First of all, on the safety and effectiveness. There was one particular study who very much looked at the effectiveness and safety of radial shockwave for calcific tendinitis of the shoulder. They had a positive result in reducing pain and improvement of shoulder function after 4 weeks, and they reported no adverse effects. There was no sort of proper placebo group in this study. They just had a less active similar therapy group, which basically meant that in that particular group of patients or subjects, they still were getting shockwave treatment, but the amount of impulses they received was less. We also know from a study who looked at general sort of tendinopathy, so they looked at elbow, shoulder, Achilles, gluteal tendinopathy, and used the same principle of treating those particular tendinopathies, and they found significant improvements in pain, functionality, and quality of life. And again, no adverse effects were reported within those studies. So we know that it's definitely a safe treatment to do. As you may now know, we're also using it now in neurology. So these are sort of things that you can mention to your patients, that it's used in so many different aspects of medicine that there are really no sort of significant safety issues. What about sort of changes in pain relief and successive treatments? So one particular study looked at using radial shockwave for symptomatic calcific shoulder tendinopathy, and basically they had 76 subjects, and they were using a Storz radial machine. There was a minimum of 3 sessions for each subject, and the energy was done to tolerance. So the minimum was 3, the maximum was 5 sessions, and they reported a 52% reduction in pain score immediately post-treatment, going up to 88% reduction in pain score at 12 months. They reported an overall success rate of 92% at 12 months, but also mentioned a 7% recurrence rate at 12 months. Other question, obviously, is the resorption of those calcific deposits. So trying to, get the body to reabsorb them to restore the normal function of that tendon. So this particular study reported a complete resorption of 55% and an incomplete resorption of 44% in a subject group of 241 patients. Of the 55% that had complete resorption, they also became symptom-free in 81% of cases, where the incomplete resorption was only 23.4%. So what if we compare shockwave with other types of treatments? Then shockwave therapy versus local steroid injection, which is a study from last year, and they found that there was a statistically significant improvement actually in both treatment groups in follow-up in pain score, tenderness, range of motion, and strength. However, there was no significant difference between the 2 groups. They had quite a small number of patients, but there was no significant difference between these 2 groups. Others compared radial shockwave versus high power laser therapy. And basically they were divided into two groups. One group would be getting six sessions of radial shockwave, about 2,000 impulses at 3 bar and 10 hertz. And the laser group received 5 sessions on alternate days, and the session lasted about 20 minutes. So they found that there were good clinical results for the laser treatment after completion of the treatment. However, patients after a month had returned back to their original symptoms. In comparison, the shockwave group had an improvement at the end of the treatment, but also still had maintained that improvement and even got better after 3 months. So demonstrating the sort of more longer term effects that we tend to see with our shockwave treatment. So if we're now looking at the focused shockwave, then basically this study by Lowe et al. In '99 looked at the pain relief, and again, you know, the reabsorption of the calcium deposits. So they reported that up to 70% of patients obtained pain relief, and you know, up to 77% of cases the calcific deposit disappeared or disintegrated. That was further supported by this particular study in 2013, looking at a higher rate of total resorption and partial resorption of calcific deposits at 6 months after focused shockwave in comparison to placebo treatment. So clearly we can see that shockwave therapy tends to have a more long-term effect, which is ultimately not, we very much want to always get these long-term results. Often patients, however, are after a quick fix, but we know that there is no quick fix when it comes to tendon-related problems. So it's very much trying to get that across to patients that the treatment that we are providing is not about, you know, short-term sort of quick fix, and then, you know, every 3 or 4 months, you know, they've got to keep coming back to have a further fix. It is very much a question of trying to provide something which gives much more long-term beneficial outcomes. This study kind of confirmed that basically after 4 years, 70% of patients treated with shockwave therapy, had still good outcome. 20% had surgery, but to have a 70% success rate after 4 years, that is a pretty good statistic. So going a little bit away from the calcific side of it, so what about sort of non-calcific rotator cuff tendinopathy and radial shockwave therapy? Well, this particular study from 2017 implied that compared to placebo, radial shockwave showed a greater efficacy in shoulder pain relief and shoulder function at 4 weeks and at 8 weeks after treatment. This study done by some Egyptian group of guys showed that there was a positive effect and that it was a safe method that can be used in addition to physical therapy. The only thing was that in both treatment groups, there was always physical therapy. So this wasn't just looking at shockwave as an entity in its own right. It was always combined with physical therapy. So is there anything that we can do to actually increase the shockwave treatment effect? And basically, we know from a study from Kim et al. That shockwave and barbotage are both successful in improving function and pain with high satisfaction rates at 1 year. Krasny et al. Looked at actually combining shockwave with barbotage and showed that there was a greater effect combining the two in comparison to shockwave on its own. And interestingly, there was no difference between shockwave therapy and arthroscopic surgery in functional improvement or pain reduction. So really looking at the fact that we should be advocating non-invasive treatments and really that surgery should be your last option if everything else has failed. So another way that the shockwave therapy effect can be enhanced is through electromagnetic transduction therapy, or EMTT. And this particular study here by Gerdesmeyer basically looked at combining EMTT with shockwave therapy and comparing it to shockwave therapy on its own. And the results were that in the combined group, the pain score had reduced greater than in the shockwave group, and the function had again increased more in the combined group than in the shockwave group on its own. So at the bottom right hand side of the screen, you can see the latest addition to the Fen Healthcare devices that they are now being able to offer to the UK market, which is called the magnetolith. So what do we have to take into consideration when we going to treat someone? Well, in our current climate, obviously infection control. You've got to think of patient position, your own position as a therapist. Do we use high energy? Do we use low energy? We're going to use a radial, a focus. Do we combine it? What do we do with it? And then also the dosage, frequency, and number of sessions. So in general, there is more research evidence into focused shockwave than there is in radial shockwave. Now that's not just for shoulders, that's for most of the shockwave literature. I would say that technique and experience is an important role. So if you have a radial device, but you'll set the patient up correctly, you find a good location and you do an appropriate treatment, I still think that you can be effective with your radial machine, rather than being all over the place with your focused machine and not placing the patient in the right position. So technique, experience, taking your time, are all important in order to maximize the effectiveness of your treatment. So obviously diagnosis, there's obviously less research evidence in tendinopathy without calcification, and the result seems to be better if there is calcification present. So this is important that you can relay that information to your patients in such that you can set appropriate expectations and inform the patient of exactly what it is that you can achieve. With regards to energy levels, well, they need to be governed by the tolerance of your patient. However, pain forms an essential part of the treatment. I normally tend to go to about 5 or 6 out of 10, but you may slowly build up to that during the course of a treatment. But in the early stages of development of shockwave therapy for tendinopathies on calcific tendons, they were using high levels of energy, which basically patients couldn't tolerate. As a result of that, they decided to give a local to the area and then provide shockwave. However, the treatment was just not effective. So we know that you need to have that pain response. You need that neurophysiological stimulus in order to be able to achieve a change in pain mechanism. So what's the patient position? So patient position is what's classed or called the modified CRAS position. So basically, any of you guys who do diagnostic ultrasound, if you wanted to look at the supraspinatus muscle, then you would place the arm into a position like that. I find that most patients tolerate this position very well, and what it does allow for is to kind of palpate, find long head of biceps, angle at 45 degrees laterally, and then identify the supraspinatus. And obviously, what you're after is that pain response. It's really quite important that you hit the spot as such, for a simple reason that it gives clarification to the patient that you find where the problem is. It also means that you can map out where you're going to deliver the treatment, basically to try and be as effective as you can be. So should we use high energy or should we use low energy? Romper et al. Looked at this in great detail, and they concluded that the results were better when the energy was higher in comparison to a low energy, but still there was a 50% improvement in the low energy group. With regards to disintegration of the calcium deposits, again, there was a better response to high energy in comparison to low energy. This was further supported by Gerdesmeyer, who basically did 3 groups. One group was treated with high energy, one group was treated with low energy, and one placebo group. And basically, the high frequency group was superior to the low frequency in pain relief and reabsorption of the calcific lesion. However, both were still better than placebo. So we can still have effects with the lower type of energy. Now, these are the energies as demonstrated by the focused shockwave machine. I'll mention in a minute about what that translates to in your radial devices. Another study looking at whether we should have low or high energy for shockwave therapy. So a 2011 study, again showing that high energy shockwave is effective for treating calcific rotator cuff tendinopathy. However, this group of people found that there was no evidence of its effectiveness to treat non-calcific rotator cuff tendinosis. So when we're looking at the energy, so a focused device uses millijoules per square millimeter, where the radial uses bar pressure. So to sort of look at what's the equivalence between focused and radial, then 0.05 millijoules per square millimeter equates to about 1 bar, and 0.20 millijoules equates to about 4 bar. I think it's highly unlikely, to ever use 4 bar on a shoulder. I mean, the highest perhaps that I've been able to get to is to about 3 bar. So in that respect, there is, I think normally you can get perhaps to about 2 to 2.5 bar, which sits sort of somewhere just above the sort of low energy of energy for your treatment. So obviously that's not the ideal position. It's more implying the handpiece to use here. So the radial, you would use anything from 2 to 2.5 bar, about 2,500 impulses using the R15 transmitter, and doing about sort of 3 to 5 sessions. With a focus device, obviously you can either go low energy or high energy, and then use your 1500 impulses and do about 2 to 3 sessions. Now, there isn't really a protocol or a script, because I think what really you're looking at is to ensure that you choose the energy related to the feedback you get from the patient and the tissue. And that's really quite important. It could well be that you need to spend a bit of time on desensitizing the tissues before you can then apply higher energy. So, so that may be a strategy where you might use your, if any of you guys got the V actor, so you could use the V actor, on the deltoid area, on upper fibers of trapezius, just to try and get the sort of hyperalgesia to settle down. Then also, you could use your D20 on the deltoid, anything to try and sort of desensitize the area, so you can then move into using higher energy, which obviously we know will have a better result in the end. Now, obviously, I'm sure that most of you don't use shockwave therapy as a single entity, and that's, I think, really important. That it's all good and well to have a shockwave machine, but it shouldn't replace it with all the other things associated with the disorder. We know that in a lot of musculoskeletal problems now, there is other things going on that we need to address as well. We mentioned earlier that 60 to 70% there is metabolic issues. So education on lifestyle, diet, general exercise, mental well-being, workplace advice, ergonomic advice, all of those things will form part of actually getting to grips with a bigger picture of how this particular condition is affecting that particular person. So in that way, there are multiple different ways of combining treatment, but as long as we have the more holistic approach to understanding the real problem that this particular shoulder pain is having to that person. So as mentioned, you could use the V actor with radial shockwave, focus shockwave, and then your rehab and education. You can use, we know that barbotage and the focus shockwave, that combination tends to work quite well. And also we have evidence that the focus shockwave plus the EMTT, has better outcomes relating to shockwave on its own. Ultimately, you will have this discussion with your patient. There are obviously costs that one needs to look into as well. So, one can look at, providing, small programs, but making sure that, you don't miss out on the critical, important parts, and then you can elaborate it and you can work as little or as much with patients as you feel that is required, but also to what extent the patient wants to work with you on achieving certain goals. So in summary, 30% failed to make progress with conservative management. Shockwave is a safe and effective treatment, but it needs to be used as a multimodal approach. We know that shockwave can be effective if we see specific, findings on ultrasound and on your X-ray. High energy tends to have better outcomes over the low energy, and also focused has better resorption rate than radial shockwave. Shockwave can be enhanced with barbotage and EMTT, and we know that it has long-term effects. And before all, it should be considered before surgery. So we now move on to the question section, and I've already been provided with a couple of questions that were provided before in the last week or so. First question was asking, somebody was asking if they are an aesthetic therapist level 5 and a sports massage therapy level 3, whether they are able to perform this particular type of treatment. Now, from my point of view, I think there are two issues here to address. One would be insurance, and two would be competency. Insurance, obviously one needs to look with their professional bodies and see if you're insured to do this type of treatment. Second, if you are insured to do this sort of treatment, then obviously you need to make sure that you get competency in using this technology. If you go onto the Venn Healthcare website and look at the CPD section, then there is a whole basically training plan, training strategy from level 1 to level 3 through to expert practice. So as long as you are covered by insurance and you get taught, then that shouldn't be a problem. A couple of other questions.
Sir, one question, please. What is more effective, high power laser or ESWT?
Sorry, I didn't hear. I can hardly hear you. It's quite. Can you type the message and then perhaps you can read it out to me?
Yeah. Raka, would you mind just typing it? If you go down to the chat room, please, just enter the question there. Okay.
Thank you. So another question that was asked, which I have addressed in my presentation. So where is the calcification usually located? As mentioned, 80% of the time it is in the supraspinatus muscle. Which area of, is it tender on palpation? Well, the answer is yes. You need to go and look for the most painful area, map it out, and then deliver your treatment there. And then with regards to positioning of the shoulder for treatment, as discussed, this is asked about a radial device, but it's not about which device you use. It's about getting access to the structure. And the best way to create that access is to place the arm into a modified clasp position, because that will expose the insertional area of the supraspinatus, which means that whether you use a radial device or a focus device, that you will be able to target the area better. So those were the sort of pre-webinar questions that were asked. So is there anything else here?
Yeah, there's one here. Would you suggest that patients who receive shockwave treatment to avoid any high impact sports activities until finishing the full treatment, 3 to 5 sessions?
Basically on most tendinopathies, I tend to get people to carry on with their training sessions. You may have to modify what they do. Yes, so I tend to get my patients to continue with their normal training schedule. You might want to give them some information on how they might have to modify it. But normally you would carry on doing what they're doing with their particular type of training. There's no need to rest them.
Fine. Well, it appears we don't have any more questions right now, but can I thank you very much for an absorbing session. I thought it was right up there with the very best we've had. And,
thank you, sir.
Not at all. So thanks very much for joining. And we look forward to, this is the last one we have for this summer. But I think they've been incredibly successful. And, thank God for Zoom. And thank God for everybody maintaining their interest, and good luck to you all in stepping forward from here on. So again, Yves, thanks very much and look forward to seeing you soon.
Thank you very much.
Bye all.
Bye-bye.